Evening, everybody, and welcome to this British Pain Society webinar, which is hosted by the Primary and Community Care Specialist Interest Group. A little bit about the BPS to get started, as always. So the British Pain Society is the oldest and the largest multidisciplinary professional organisation in the field of pain within the UK. The aims of the BPS are to promote education, training, research, and development in all fields of pain. So today, the British Pain Society has a multi-professional membership of over 800 and is a uniquely relevant representative body on all matters relating to pain, and endeavours to increase both professional and public awareness of the prevalence of pain and the facilities that are available for its management. So just to draw your attention, please, to the next annual scientific meeting, the 58th, and that will be happening between the 3rd and 5th of June 2025 at the International Convention Centre in Wales, and all details are on the BPS's website. Just a few housekeeping rules. So it does say here, type your questions in the chat box, but we're actually going to ask you to type your questions in the Q&A if possible, please. So our speaker will do their presentation for around 45 minutes, give or take. And then what time we have remaining will be for questions, and we will finish at 8:30. The webinar is being recorded. It will be available on the BPS's YouTube channel, and you will receive a link for this. Please do fill out the evaluation form. You'll get a certificate of attendance, and it's really important for us to get some feedback to try and make these webinars as good as possible in the future. Okay, so I will stop sharing. So today we are going to be discussing opioids and should we ever prescribe them. Of course, as I'm sure most people are aware, the role of opioids, particularly in chronic non-cancer pain, has been declining over the last few years, decade, and increasingly national guidelines do not recommend their use. So we want to consider today a bit about why that is, but also scenarios where perhaps we would consider opioids and how we should do that safely. So we are absolutely delighted to have the president himself to speak about this matter. I've heard him described as the sort of absolute king of all things opioids. And that's, of course, Roger Naggs. So he's an associate professor in clinical pharmacy practice at the University of Nottingham. He's specialist pharmacist in pain management as part of PICS, the Primary Integrated Community Services in Nottingham. He's a clinical academic pharmacist. His current position provides teaching and research opportunities while maintaining a regular clinical practice. Roger's main research interests focus on the appropriate use of analgesic medicines and associated clinical outcomes in healthcare utilization. He aims to promote the importance of pain within pharmacy and the role of pharmacy within pain management. Roger was the inaugural chair of the United Kingdom Clinical Pharmacy Association Pain Management Group. He is, of course, the current president of the BPS, after having been vice president, honorary secretary, and co-opted and elected council member. In 2019, he was appointed a member of the Advisory Council on the Misuse of Drugs and is chair of their technical committee. In addition, he has associations with several other healthcare policy and government organisations in the UK, including the Faculty of Pain Medicine and the Care Quality Commission and NICE. Roger has also chaired the European Pain Federation COVID-19 Task Force since March 2020. So, without further ado, and it gives me great pleasure to introduce Professor Roger Naggs to give our presentation this evening.
Thank you, Graham. So I've been given this very interesting title, Should We Ever Prescribe Opioids? And I think the first thing I would like to say is to remember that opioids certainly continue to have a place in pain management, particularly for acute pain following trauma or surgery, and also for pain at the end of life. But I think that Graham's question in the title really referred to persistent or chronic pain. And the evidence, as he's already alluded to, here is much more limited and is largely of a short-term duration. Where opioids are prescribed, it is essential that there is regular monitoring, both for efficacy and effectiveness, and I'll talk a little bit about the difference between those two terms in a few moments, but also in terms of their side effects and harms that are associated with opioids as well. And I think really key is that this requires collaboration and clear communication between different teams, whether they be based in primary care, whether they be based in secondary care, that there is a very clear communication between teams. But before we get to thinking about what is the current evidence, it's worth remembering that both the use of opioids is not new, and they have been used for both their analgesic effect going back millennia. Their first documented use was around 2,000 to 3,000 BC, but equally concerns about their misuse are not new either. This slide comes from a letter that was published in 1851, and it's a bit like a swinging pendulum, and we seem to go from a time when opioid use is much more liberal, and then the concerns become more prominent, and there's a swinging over the centuries in terms of whether opioids are in favour or out of favour. I think it's really key that where we are today is to put that into some sort of context, and that and ensuring that opioids are being used appropriately, and that they are providing benefit for those people for whom we are prescribing them. The recent concerns regarding dependence and addiction are perhaps best summarized from some work that was undertaken by the MHRA, and this information comes from a summary that was produced in the Drug Safety Update in September 2020. And you can see there are a range of different points that they recommend healthcare professionals to take into account during these discussions with individuals. I'd just like to draw your attention to one of these, and that relates to the idea of agreeing with the individual that there is a strategy around how opioids are going to be used, but equally important, at the beginning of treatment, have the exit strategy planned and agreed with the individual as well. let's now move on and think about the evidence regarding both benefits and harms relating to the use of opioids for persistent pain. This very nice figure comes from a publication that is now 20 years old, but I think it very clearly shows that in the trials that had run RCT trials that had been conducted at that time, that opioids have efficacy for both a range of neuropathic and musculoskeletal pains. You'll see that I've highlighted in green that response of 30% that is sometimes considered to be the minimum clinically important change in terms of pain relief. However, you can also see that the placebo response is also high as well. And for those trials where the active response was highest, the placebo response was highest as well. And they make a comment that after these trials that were of relatively short duration, only 8 to 10 weeks, that only a small proportion of people decided that they wished to continue with the opioids after the trial had finished. This more complex meta-analysis comes from some work that was used to inform the development of the most recent CDC guidance in the States. And you can see that including a larger number of trials that and when these are combined in meta-analysis, there was only a 0.8 reduction on a 0 to 10 scale, which would be considered to be not clinically meaningful or significant. And that there was the effect that was noted in these trials was larger in earlier trials, and this has diminished over time. Trials that used an enhanced enrichment and randomized withdrawal design had a larger effect size, and those that used a crossover design were again produced larger results than parallel groups. So this is saying something about the importance of the way in which the trials are designed and how we then interpret the results from these trials. Back in 2015, there was no study that had looked at the long-term outcomes, both in relation to pain, function, and quality of life. And it was only in 2018 when the space trial was reported. And this was a relatively small trial of 240 individuals in back pain and hip and knee osteoarthritis. And you can see that that the pain intensity was significantly better. So improved pain relief in the non-opioid group over the 12-month period compared with the opioid group, suggesting that opioids have limited effect with over longer periods, and also that the side effects were significantly more reported in the opioid group compared with the group who were taking non-opioid medicines. One of the interesting things that we do need to give some thought to is what opioids are actually being prescribed for, and is it the reduction in pain that is the primary outcome, or are functional improvements more important? There have been a smaller number of studies that have looked at the functional outcomes, and undertaking a meta-analysis, there is a small to moderate effect size on in terms of that opioids have some benefit in terms in improving function. You can see that there are a range of different questionnaires used from the ranging from the brief pain inventory, the pain disability index, WOMAC specifically for osteoarthritis, and Roland Morris disability questionnaire. I'm going to now move on and think about the harms, so the other side of that pendulum. And obviously the most significant harm relating to any medicine relates to mortality. These data are from the Office for National Statistics and relating to drug poisonings, specifically within in England. You can see that here there are two drugs that have consistently had a higher number of deaths associated with them than other medicines. The first top blue line is heroin and morphine. So this is a mixture of both illicit opioids, and also there are no doubt a few deaths related to prescribed morphine within that as well. But given the way in which post-mortem samples are analysed, we're unable to dissect those that are related to prescribed medicines and those that are related to illicit heroin use. The other the second largest component of drug-related deaths are those that are associated with methadone, clearly relating to the population who are being prescribed this as opioid substitution therapy. For all other opioids, the number of opioid-related deaths are much smaller. But if we change the scale of the y-axis to look at those in a little more detail, I would just like to highlight to you that there have been an increase in the number of deaths relating to some of the semi-synthetic and wholly synthetic opioids, such as oxycodone and fentanyl. And although these numbers remain relatively small, I think it's an area that we do need to continue to be vigilant and watch over the next few years to assess where the trends in the use of these the deaths associated with these medicines occur. Just to give some geographical variation, these are the drug-related deaths reported from Scotland, and you can see that the two most common, again, heroin and morphine and methadone. And although from a much smaller population, the incidence of these is significantly greater than in other parts of the UK. There have been a couple of other studies that have assessed the risk of mortality associated with prescribed opioids. This first study that I'm showing you comes from the large genomic study called UK Biobank. You can see with just under 500,000 participants that just over 5% or 1 in 20 people regularly being prescribed opioids, and that over the follow-up period that there were more the mortality associated with those taking both weak opioids and strong opioids was significantly higher than those people who were not prescribed any opioids as well. And even adjusting for a range of different lifestyle and socioeconomic factors, there remained an increased mortality associated with these with opioid medicines. So prescribing of opioids is certainly associated with an increased risk of mortality. This other study comes from some work we did in Nottingham a few years ago, where we were using a anonymized GP database that we were able to link to those ONS death certificates, and then look at the opioids that they were prescribed in the year prior to the individual's death. And you can see, although the numbers of deaths were actually relatively small, over a quarter of those people did not actually have an opioid prescription in the year prior to death, which either means that they were obtaining their opioids illicitly, or that they still had significant supplies from previous prescriptions. There was a dose relationship to mortality. So, and those people who prescribed doses over 120 milligrams a day, an adjusted odds ratio of just over 2. Also worth remembering that there was an increased risk of mortality associated with other centrally acting depressant drugs, such as gabapentinoids and some of the older antidepressants as well. So the significance of polypharmacy in some of these deaths is potentially important as well. So moving away from mortality to think about other physical and psychological harms that are associated with opioid medicines. You'll all remember back to your basic pharmacology, and there are a range of side effects that are very predictable based on the pharmacology of opioids, such as nausea and vomiting, risks of respiratory depression. But there are also a range of other certainly physical harms that we need to be aware of, such as an increased risk of sexual dysfunction, increased risk of fractures, and also of myocardial infarction as well. So we do need to be mindful that there are other risks that are not necessarily directly related to the underlying pharmacology of these medicines. I wanted to show you some figures relating to the risks, specifically within the UK population. This is one of the few studies that I'm aware of that has looked at a range of both physical and psychological and psychiatric conditions. This study comes from Keele University, looking specifically at musculoskeletal conditions and a new long-term prescribing of opioids over this 11-year period. You can see that there were about 100, just approaching 100,000 individuals, and that again, these dose-related harms from trauma, falls, GI bleeds and pathology, but also a range of psychiatric conditions, such as an increased risk of addiction, overdose, and both accidental poisoning and also self-harm as well. You may remember from teaching years and years ago that when opioids are used for the treatment of pain, that the risk of addiction is thought to be relatively rare. And this comes from this very short letter that was published in the New England Journal of Medicine in 1980, in which they reported that there were of nearly 12,000 individuals who received at least one opioid prescription. There were only 4 cases of what they were considered to be addiction. And this is one of the few cases where nearly 40 years later, this paper was retracted on the basis that it had been so heavily cited to suggest that opioids are not associated with addiction. The most recent estimates that I am aware of in terms of what are the rates of misuse, it comes from this systematic review that was published around 10 years ago. And you can see it very much depends upon the definitions that I use. So problematic use ranging from almost nothing to over 80%. Misuse being between a quarter and a fifth of individuals, and true addiction being between 1 in 12 and 1 in 10 individuals. So quite a range of values that have been quoted in the literature. And this then brings me to a little thought around the differences between particularly randomized controlled trials and how medicines are used in the real world, and shall we say, using real world evidence. If you remember back to the slides that I showed you that assessed efficacy, that most of the trials that have been undertaken tend to be of relatively short duration for registration purposes, for chronic pain conditions. These do not need to exceed around 3 months. So this is the majority of the evidence that we have, and this has been then extrapolated to use over much longer periods. The populations within the trials tend to be a much more selected population, having more confirmed diagnoses, and also there are a range of exclusion criteria that do not necessarily reflect the way in which opioids may be used and prescribed as part of routine clinical care, as opposed to within the trial situation. Obviously, there is much closer follow-up within randomized controlled trials, particularly a trial that is of 3 months duration. There might be follow-up on either on a weekly basis or certainly a fortnightly basis. So patients are going to feel better supported. There are plans within the protocol around management of side effects, and very often the use and availability of rescue medicines as needed as well. But in real life, this it is usual for, or certainly possible, that people are going to receive more than one intervention at a time. And so it does not necessarily reflect the controlled nature of a traditional randomized controlled trial. And of course, it's well worth remembering that even if there is evidence of efficacy in the short term, that is not a predictor that there is going to be continued effectiveness over much longer periods of time, as opioids may well be prescribed for. NICE, there is recommendations around NICE from a population level, and with a few exceptions, they are all certainly rather negative in relation to the use of opioids. So consider weak opioids with or without paracetamol for acute low back pain, only if an indicated but not recommended for routinely managing acute low back pain, managing chronic low back pain or sciatica as well. In terms of osteoarthritis, do not routinely recommend opioids unless they are used infrequently, and other treatments are contraindicated, and don't recommend opioids for strong opioids for osteoarthritis. In terms of neuropathic pain, tramadol, so this is specifically within the non-specialist setting, tramadol only for rescue, and do not start for neuropathic pain unless advised by a specialist and specifically in this case morphine and tramadol are recommended, and the guideline that relates to the management of chronic primary pain, that opioids are not initiated either. However, of course, these are very much based at a population level, and they don't necessarily reflect you need to think about how this is applied to the individual that you have in front of you. So I want to look at the European Pain Federation recommendations around the use of opioids for chronic non-cancer pain. And they divide their recommendations into both primary and secondary pain. They suggest that opioids may well be recommended for a range of both musculoskeletal and neuropathic pains, but you can see that the level of evidence on which these recommendations are based is exceedingly low. They then potentially say consider for a range of other secondary types of pain, for many of the types of pain that may well be seen within particularly specialist settings. And then they do not recommend opioids for what would be considered chronic primary pain conditions. So here headache or a facial pain, functional disorders, visceral pain, primary musculoskeletal pain, and also where pain is part of a psychological presentation as well. And I think this is really key in terms of the way in which we think about how we operationalize and think about how we may use opioids effectively for these chronic pain conditions. So I'd just like to think a little bit about, so if you do consider that for that individual patient, that opioids may well be worth considering as a trial, and I stress that should always be the way in which they are seen to be considered in the first instance, it goes without saying that they should be used within the context of a biopsychosocial framework, addressing all parts of the biological, the psychological, and the social components. Ensuring that you have explored with the individual what they can do from a self-care perspective, and also appropriate non-pharmacological treatments, and have tried evidence-based non-opioid medicines before resorting to considering opioids. I think realistic expectations are extremely important, and this is for both the healthcare professional and the person for whom opioids are being prescribed. It is very unlikely that the opioid is going to provide complete pain relief, and it's important that the individual is aware of that. And so having strategies that they can draw upon is extremely important. Setting goals with the individual, ensuring that they are realistic, is important as well. And also that this is very clearly documented, so that if the person is being reviewed by another person next time, it is very clear in terms of what those goals were agreed, and where possible that they are of a functional nature, as opposed to simply a reduction in pain intensity. Need to have a conversation around the intended benefits and also the harms that may be associated with opioids, as you would do for any other medicine. And think back to the advice and recommendations from the MHRA, and also the importance of being able to have a conversation around the risks of dependence, tolerance, and also the potential for unintentional overdose, and how this may be reduced. And then also providing clear communication for the person to take away and consider as well. And as I alluded to at the outset, agreeing with and having an exit strategy at the beginning, as opposed to only thinking about it when it appears that opioids may not be working. In terms of practicalities, key being to start low, so low dose, and to go very slowly to titrate and increase the dose. Obviously, regular monitoring is extremely important. The EFIC, European Pain Federation guidance, recommends review at least every three months, and there's three components to this review. First of all, to ensure that the opioids are providing the benefit that was intended, so that the goals have been met. That are there side effects or harms that may be associated with the continued prescribing of opioid, and also, is there any indication of an opioid use disorder or diversion or non-medical use. And they also suggest to consider a small dose reduction every 6 months in order to assess any ongoing benefit as well. So it's rather than just solely relying upon that review process. I'd just like to end with a few thoughts around a particular group of individuals, and that is where opioids have been prescribed after a surgical procedure. And the reason why I think this is important, because this highlights one of the issues that I was describing at the very beginning of the presentation around the working across interfaces between primary and secondary care. This came from a cohort study that we undertook over the COVID pandemic, and it was basically a notes review over a 1-month period within 14 trusts across the UK. You can see that included just under 500 individuals, and for the majority of these individuals, there was a specified duration of opioid prescribing at the point of discharge, but this was really just how much was actually being supplied at the time of discharge. But a similar number, approaching 3/4, had no advice on what to do once the person had left the hospital around dose reduction and deprescribing as well. And I think this just goes to show the at the time the lack of formal guidance that was being provided to particularly the most junior members of the surgical team, with there being no formal guidance on discharge analgesia, and also the lack of training for prescribers on the on discharge prescribing of analgesic medicines as well. So I think this is an area that a group of individuals for whom that we could do and make significant progress in terms of improving the care of these individuals, particularly around that interface between secondary and primary care. And I'd just like to introduce the concept of opioid stewardship. This is a concept that is more developed in some parts of the country than others. This definition on the top of the slide comes from Canada and describes opioid stewardship: coordinated interventions designed to improve, monitor, and evaluate the use of opioids in order to support and protect human health. I would like to suggest that this is not this is a concept that needs to be embedded across healthcare systems, and that we need to think about improved communication, just as I've been describing within the surgical population, that people need to work together with a common purpose to promote the rational and judicious use of opioid medicines, and consider the impact of what your intervention does across the whole system, and not just within your within your individual service. You need to think about the availability and provision of specialist services, whether these are based within and their availability both within primary and within secondary care settings. Think about the other treatment options that are available, and also consider what might be unintended consequences of making changes to opioid prescribing. And I think key to all of this is improved analytics and availability of data, so that we are able to monitor and assess these changes. And I will end with these 5 key messages that come from the front page of the Opioids Aware website, which I'm sure is something that many of you are aware of. If you're not, I would certainly recommend that you have a look at this website. I will just say that it is in the process. All of the information is in the process of being updated at the moment, and it will there will be quite a significant update over the next few months. So watch this space. Thank you very much.
Thank you ever so much, Roger. That was a really comprehensive and fascinating talk, and thank you ever so much. How are you doing? Are you all right to take some questions?
Yep.
Fantastic. So we've got a few that we can get started with. If anyone else has questions, obviously we've got Roger's expertise for a little bit now, so please do get them in the Q&A. So I'll start with this, Roger, because it's kind of come up in a number of about 3 of the questions. So, and this is around the whole sort of 120 milligrams morphine equivalent daily dose, and whether that value is still really right, or whether we should be following suit with other countries, Scotland included, I believe, who are lowering that level.
I showed you that there are quite clear dose relationships for many of the harms that both physical and psychiatric harms that are associated with opioids, and many countries have over the years looked to reduce the shall I say, the maximum recommended dose. I think it is fair to say that in the next or within the update of Opioids Aware, that figure will be lower than 120 milligrams. And there are a range of different values that have been used in different countries, ranging from around 50 milligrams to around 90 milligrams. I think it's also perhaps worth putting that 120 milligrams into some sort of context, in that when that recommendation was originally made, it was a very pragmatic recommendation on the basis of the evidence that we had at the time, but equally it was pragmatic in terms of what it represented, in that it was the equivalent of 60 milligrams of slow release morphine twice a day. And I think one of the issues that we have with other, or some other lower recommendations, is that you have to, or the maths are harder to compute, and so I think the key is having a figure in your mind with which you feel comfortable. You know, as I say, that we know what the ranges that have been used both within the updated CDC guidance in the US a couple of years ago. The Canadians are going through a review process at the moment, and also in Australia. And I would say now it's probably somewhere between 60 and 80. It's in terms of a figure to have in mind. But I think you do need something that is practical as well.
Sure. And would it be fair to say, Roger, as well, that number one, on a case by case basis, if you take an older adult who's frail, etc., then we're not going to want to be anywhere near 120 milligrams a day, ideally, and perhaps secondly as well, if people are initiating opioids, from the start, and they've made 1, 2, even 3 dose increases, and they're getting no effect whatsoever, then we don't want to just keep going and going up to 120. If it ain't working, it ain't working.
Exactly, that's right. And you'll get an idea actually relatively quickly. I think one of the other things to bear in mind is what you're actually prescribing, certainly initially, and you will get a reasonable idea of whether a pain is opioid responsive by using a relatively small dose of a short-acting formulation, rather than initially always resorting to a modified release formulation. And I think you look at the European Pain Federation recommendations around the conditions where they potentially say either opioids may be recommended or may be considered. I think you do need to think about it within the context of the individual, and also that if somebody is using an opioid appropriately or taking an opioid appropriately, and is only using a couple of doses of a quick acting formulation a few times a week, that allows them to be more physically active, to go to the gym, to undertake some physical activity, then that use is entirely appropriate. And I think we need, and so it is very much thinking about the individual rather than necessarily having, and these are very much guidelines and tramlines as opposed to a strict protocol.
Sure. Yeah, absolutely. Okay, so kind of linked to that, somebody asked a question here that they sort of been trying quite hard in the community to taper opioids down to a safe limit, maybe around about that sort of high risk threshold, and then finding that other health professionals within the community then escalate the dose again. So a kind of bouncing around effect there. I'm sure you've got a little bit of experience of that, Roger, and any kind of advice or guidance you can give.
I think I alluded to the fact that clear communication is obviously extremely key to this. Where possible, having one person doing the prescribing can be extremely helpful. And I know some practices locally who have agreed where there is one person or maybe one of the GPs together with the pharmacist who will oversee the prescribing for those people who are either taking or have regular prescriptions or are taking large doses, so that there is that continuity. Equally, I think the personal contact can be extremely helpful as well. So certainly locally, I'm very keen to reach out to individuals and maybe have that one-to-one conversation as well, in that in that you then get a sense of where the individual's coming from, what the challenges are. As a GP, have you any thoughts on the subject as well?
Well, I work in the pain clinic most of the time now, so I don't really see it too much from the other side. But I think, yeah, I mean, I think there's a lot of work to be done, isn't there, in terms of changing hearts and minds across all parts of the health sector, and just really the more we keep talking about it, and the more we keep banging the drum, the better. And like you say, I mean, yeah, if somebody you sort of notice somebody who's doing that quite repeatedly, offer to have a chat, offer to speak to them about it. They may not take you up on it, but you can try. And yeah, sure. Okay, so the next question is an interesting one here. So this is about the Opal trial from 2023. So of course that's opioid analgesia for acute low back pain, acute neck pain. And for people who don't know, that was quite a significant trial because they showed at 6 weeks follow-up no mean difference in pain levels for people on opioids compared to people on placebo. So the question is, do you think we will ever achieve not prescribing opioids for acute back and neck pain? The prescribing leads to addiction in chronic pain.
Discuss. Discuss. I would like to think so over time, but I think it's the sort of thing, it's the sort of, shall I say, prescribing folklore that takes a lot or a long time, and probably it's a generational effect as well. And so one would hope that with those people who are either young in their career or studying at present, that actually with more, shall I say, more knowledge around modern pain science, and also the lack of effect of medicines for many types of pain, that it will hopefully have an impact on practice. But I think we all know that changing our own behavior and prescribing can be a challenge, and it's something that you need to continually work at. And so in answer to the question, I would like to say yes, but I probably can't see it necessarily anytime soon.
Yeah, absolutely. And I mean, one of the things with the difficulties, I guess, with many of these trials and mean values, kind of mean value at 6 weeks, is that you're essentially drawing a line through it, and you're going to get a load of people who don't respond to opioids. You're going to get a few people who do respond to opioids, and that's going to bring you out at around about the placebo level. But because you've always got some people out there who do respond to opioids, and they'll tell lots of people about it as well, then that's quite a tricky thing to manage, isn't it? And I think pain research and opioid research hasn't quite worked that bit out yet.
Most definitely. And I say to so many of the patients that I see, not just relating to opioids, if there was a way that we knew which medicine, if there was some sort of test, whether it be genetics or some other screening that we could do that would help us predict how you are going to respond to a particular analgesic medicine, or know which medicines are more likely to work, then it would be a great step forward. But I think that is probably even further in the distance than what we were just talking about in terms of changing prescribing.
Yeah, sure. And of course, the Faculty of Pain Medicine, they include that within their opioids aware statements that there will be a small number of people out there who will respond, but that's
Yes.
almost impossible to know at initiation.
And I think it's, as I alluded to on a few occasions, thinking about what or where you're able to keep the dose relatively low and intermittent, then actually that use is probably is much more appropriate than somebody who's taking a very large dose of a modified release preparation on a regular basis.
Yeah, yeah, absolutely. It's yeah, that's that. I mean, that's a really interesting subject in itself that we could possibly dive into a little bit more if we have time. But we'll go through, I think, what's here first. So I think you've answered this one anyway, Roger. This one was just about the incidence of addiction after starting opioids. So you put some slides up about that one.
I think with that, addiction is a phrase that is gone out of sort of more common parlance, and certainly in the US, there's a lot of literature around opioid use disorders.
Sure.
And I think we do need, or we need to remember the difference particularly between dependence and what is historically would have been described as addiction or as an opioid use disorder, in terms of the opioid being the only thing that you can think about, and the craving and the way that that is the only thing that you're thinking about.
Sure. Yeah, so that's, obviously actual brain changes within the reward systems of the reward pathways of the brain, rather than just tolerance to, within the pain system, essentially. Yeah, absolutely. So this one is a bit tricky. I'm going to just read this one, if that's okay. It says, do all the mortality rates show a difference between those who are prescribed opioids from primary or secondary care and those who purchase it from other sources?
So the mortality, the ONS mortality, is the two combined, and we're not able to distinguish between those that are prescribed and those that have obtained either from family or friends or from illicit sources. The only way to be able to do that in the UK at the moment was, or is in a way similar to the CPRD study that I showed you that we undertook a few years ago, where we were able to link the prescribing with the mortality for those individuals. And as you may recollect, that actually there were a quarter of people who didn't have a prescription in the year before death.
Yeah,
which I think so that does question where is that coming from. But unfortunately, in terms of the way in which deaths are recorded and then reported through ONS, there is no way of being able to distinguish. The one thing I will say, though, is that more recently, over the last few years, they have started to report the number of deaths that are associated with synthetic fentanyls. So, in other words, these are not fentanyl that we are all familiar with as a prescribed substance. These are synthetic analogues that have been a particular issue for misuse in the States, but less so here. But the ONS have specifically pulled those out as a separate line, so you know that they are illicit. But the numbers are relatively small. I can't remember the figures for 2022, but I think it's less than certainly less than 50 a year. So they're compared with the other opioids, much smaller numbers. And of course, the other issue with the mortality is that because heroin is metabolized to morphine itself, that it's impossible to disaggregate those deaths that are related to illicit heroin and prescribed morphine as well.
Yeah, that's fascinating stuff, Roger. That is, yeah. Well, someone has just popped a question up about fentanyl, actually. So we'll just go to that one as you're on the subject. So the question is just, given the increasing use of fentanyl and the dangers associated with it, do you think that it should be specialist initiation only?
That's an interesting proposal. Actually, if you look at the numbers of prescriptions for fentanyl, they have been gradually reducing over the last few years. So the message around how potent it is has gradually been getting out to the wider community. I think, and there may always be exceptions to this, because nothing is never so black and white in medicine. But I think there is some logic to that proposal, in that it's not recommended that fentanyl is initiated in an opioid naive or for an opioid naive individual. So you're talking about somebody who's already been taking an opioid. And I think there probably needs to be some good justification around having such a large opioid equivalence as being, shall I say, continuous background.
Yeah.
And in some areas of the country, it may be a way to help minimize prescribing.
Yeah, sure. I have actually proposed that in my own local area: fentanyl, oxycodone, and high-dose buprenorphine in non-cancer pain to be specialist initiation only. Okay, so quite a few questions now, which is fantastic. So here you go, Roger. How do you explain opioid-induced hyperalgesia to patients in a way that makes sense to them?
So I talk to them about an increase in pain with an increased opioid dose, basically, at a very simplistic level, so that rather than an increase in dose providing better pain relief, that actually it then causes an increase in pain. Or a change in pain sensation, so that their pain is different and more diffuse as well. So a change in characteristics as well as the dose-related effect.
Sure.
I think it's one of those phenomena that we could debate, but we could probably have a whole session talking about opioid-induced hyperalgesia specifically, because there are some people who believe it is a true phenomenon. Particularly the chronic pain setting, there is also people who would say that it's not a true phenomenon.
Well, like you say, maybe a webinar on opioid-induced hyperalgesia then. Okay, so this next question: we regularly have patients referred to our pain clinic who have been started on strong opioids for both primary and secondary pain. where they cannot recall an end of opioid therapy was discussed. Therefore, their expectation is that it's long-term. Very difficult to then have that discussion. Many of our patients don't see starting an analgesic as a short-term option for chronic pain. Yeah, I mean, sure. I mean, a lot of patients are, I'd say perhaps even most patients are extremely surprised when you tell them that it may not be the best.
And I think it's something that we're all probably guilty of. And that was one of the reasons why I felt that in terms of the MHRA advice, I think, and why I wanted to highlight it tonight, in terms of having that plan at the outset and also explaining it and or having that conversation before you actually start the opioid. And that is, I think that is a change of practice for many people, specialists as well. And so it's and I think the population that you have just described are very diverse in themselves. So those people who have been taking and been prescribed opioids for sometimes many years are a very different population to those people who we may be thinking about, is an opioid appropriate now? And I think we need to reflect to the individual that not necessarily our own individual contribution to the issue, but actually our acknowledgement that evidence does change and it moves on, and that we are reflecting what is current best practice.
Yeah.
And yeah, I think everybody who comes from a specialist setting will probably see many people like that who people who've been prescribed opioids for very long periods of time, and this is a big challenge for us all.
Yeah. I think if we extrapolate from that question, it's a great question, actually. If we extrapolate a little bit, we kind of almost get into the crux of this question about should we ever use opioids a bit, because, you know, we have nice guidelines that pretty much say, you know, no long-term regular opioids in chronic pain. We have a research base which pretty much supports that idea. As you said in your slides, in the European Journal of Pain, you know, there's still some suggestion that we should be considering in secondary pain conditions. You know, the problems with long-term, whatever your pain, really, the problems with long-term opioids, developing opioid tolerance, developing opioid dependence, these are properties of the drug and the way the drug acts rather than the condition. So you then have patients with chronic primary pain who actually maybe have some codeine or whatever, and they might be using it very intermittently, and therefore in, you know, a way that sort of works with the drug and actually getting some benefit from it. So we've got to somehow try and put all this together. And when we do, let's say we take a patient with chronic secondary pain, you know, got clear elements of sort of nociceptive pain and things, and we start an opioid, we do a so-called opioid trial. Roger, what do you think people are actually trying to achieve then? Like, are they thinking, well, I'm going to give an opioid for a short period while this patient does some rehab work? Are they kind of thinking they are going to do it long term? What are we actually doing when we do that?
And that's where I think the expectations are key, and it's not just the expectations that we're giving to the individual, it's what are our own expectations and what our own perceptions. And I think there are perhaps several ways to think about this. We've talked a little bit about opioids in acute spinal pain and the Opal trial. And I think for a substantial proportion of individuals, opioids may well be started in good faith that this is an acute issue.
Mm.
And then it's only as time progresses that this then becomes what is then quite clearly a persistent or a long-term problem. And so they may well be started in good faith that actually this is only intended for a relatively short space of time. But I think they should not ever be seen as being the only intervention, even when they're used in that way, and that they need to be used in combination with a range of or addressing the psychological and the social at the same time. Sure. And whether that be through thinking about self-care, whether that be thinking about more structured exercise and psychological therapies, the opioid should not be seen in isolation. And I think that is really the key. But also knowing that actually they should be used not necessarily, and we need to be very clear in our minds as well that they're not going to provide complete relief, and that it always having that functional element in the back of your mind.
Sure. Yeah, absolutely. Medicines is one piece of a pain management jigsaw.
Yeah, and I think historically, and again, you may have some thoughts from a GP perspective, that when somebody comes into your surgery and when something seems acute, you reach for the prescription pad, but don't necessarily, and historically may well that was your first solution, but have given less emphasis to the other components.
Mm. Yeah, no, I think you're absolutely right. I mean, I think all of us who have trained within a kind of Western medical framework, we did train within a very biomedical framework, and it is a relatively recent thing that we're thinking much more from a biopsychosocial standpoint.
Now, a few people may have heard me say in the past, whilst I think biopsychosocial is a big step forward, it still has the bio at the front.
Yes.
And really we should be thinking psycho-biological.
Yeah.
But that's perhaps for another day.
I was going to say, we'll maybe leave that an argument around the BPS for a different day. So I'm going to just try and pick up the pace a little bit, because we'll try to finish for 8:30. So this is a statement really, leads into some other things, but absolutely, Sunil, we need not only patient education, but healthcare professional education. And this person here just highlighting the problems around opioid tapering, that of course, we are really talking here about the initiation and the escalation of opioids, but people who are already on opioids need to be treated individually and it's very rarely appropriate to be aggressively or forcefully or non-consensually tapering opioids. And this person just highlighting that that is, of course, a big problem. And I mean, from my own experience and what we've done locally, I would say this person's asking, what do we do about it? And I would say, well, you've got to try and produce local guidelines and get them out there and have these conversations, which is, you know, what we've done. Is that fair to say, Roger?
I think so. Yeah, I agree with and everything that you have said. I think overall, one would say it is a minority. It's but there may be some people or individuals who have strongly held beliefs or see things in a very black and white perspective. And I think in order to prevent that pendulum swinging either from to greater use as we have done in the past to a much more restrictive practice, that it's about putting the individual at the center.
Sure. Yeah, absolutely. So, Roger, we've got about 8 minutes. We've got some amazing questions left. Okay, so this is going to get quick fire now, but I think we should try and answer a few of them because there's some really important ones. So, this one, there's one here that relates to cancer pain. Basically, can you give us a 1 minute answer if you know much about this? You know, what's the evidence like for cancer pain as opposed to non-cancer pain?
I think you need to think about what are the underlying mechanisms. And there is certainly some evidence that for neuropathic pain, that opioids may be more sensitive than and more effective than for some of the other conditions that we've been talking about. And so I think there are probably two, maybe you could say there are three different populations. There are those who are having active treatment. There are those who are at the end of life, but then you've also got an increasing number of cancer survivors as well. And they may present with other types of pain or pain that is not related to their cancer as well. I think we need to be very mindful of that fact.
Sure. Yeah, absolutely. It's not often hard to completely tie down that, you know, what is related to cancer and what is not related to cancer. Another really important question here, actually. CDC recommending that long-acting preps of opioids more related to overdose. So if we do use them, should we stick to short-acting preparations?
If I had my way, yes.
Okay.
Very short, very short answer. I think that goes back to what sort of some of the messages I've been talking about in terms of intermittent use. And so by that, you anticipate that you're talking about a short-acting formulation, is certainly the way to go.
Sure. Okay. I don't think we necessarily do pharmacology in this in this forum, but this question says, what are the mechanisms of opioids in neuropathic pain? I'm not sure that's a 1 minute answer, but
no, I don't. If you don't mind, I'm going to pass on that one.
Pass on that one. I think opioids primarily affect transmission across the first synapse between first and secondary order nociceptors. So I would say that would be, you know, much the same for neuropathic pain, really. But I don't know. We haven't got expertise in that one, I'm afraid. Okay, so this was a quick one. I mean, this is related to what we were saying on fentanyl, really. Is there a case for limiting opioid prescribing for non-cancer pain to just using buprenorphine patch up to 20 mics?
I think Um, one of the things that I saw at some point over the last couple of weeks, that actually within the, I think it's the BNF app I was looking at, they have now put in markers for the patches around doses that should not be or that should not be exceeded within a non-specialist setting, and that's really using that 120 or 120 equivalents. And I overall I would probably agree with that. You know, and if you think about what the rough equivalence is, I can't remember what a 20 mic is off the top of my head, but it's you're beginning to get closer. You're getting certainly. I think it's about 80, between 80 and 90 milligrams a day. So one could say that there would be rationale for not going above that.
Yeah, sure. I mean, when you go from that 7-day patch to 4-day patches, then you do jump quite significantly, don't you, from around 50 up to around about 80, that kind of level. So yeah, I would definitely agree with that. This question is apart from the work in Sunderland and Newcastle, which I think is referring to painkillers don't work, are there any other kind of health public awareness campaigns going on around opioids?
Not specifically opioids that I'm aware of.
Not nationally, I don't think, no.
Yes, certainly not nationally. There's the health innovation networks have been doing a lot of work within regions, that's been an interesting process to watch, in that their original focus was originally to try and reduce high dose opioid prescribing, but actually now they've really morphed into thinking about other ways or supporting people in other ways. So looking at non-pharma management.
Yeah, sure.
And so although they're not directly relating to opioids, I think there are lots of local examples where it's more around managing chronic pain more effectively rather than necessarily opioids per se.
Yeah, absolutely. I think there's lots of local work going on, as you say, and I know health in our network, Health Innovation East Midlands, have been very supportive of us locally. So we've got 1 minute, Roger. I'm going to finish on this question here, because I think it's sort of actually quite a nice little sort of type of summary and a nice sort of philosophical thought. So this person has said, as a newer consultant, it is disappointing to see our previous consultant colleagues promoting and prescribing opioids at an industrial scale and showing no effort at reducing them. Inheriting these legacy patients leads to difficult conversations. I'm not so sure about that, but it's time to name and shame, it says. I'm not so sure about that. Maybe bring disciplinary actions. So now, and just pointing out there's some issues around cannabis now. So it's asked for your opinion. So within the spirit of learning and support and education, which we're all about here, your opinion to end, please, Roger.
I think, as I have alluded to, evidence does change, and we need to reflect that changing evidence. I'm not going, if you don't mind, I'm going to be a politician and not answer the question directly, but I'm going to say, or answer it in a slightly tangential way, is that so often, if I get up and speak at an audience that is primarily GPs in primary care, they say that all of the prescribing starts in secondary care, and you get up and speak to a secondary care audience, and they say that all of the prescribing starts in primary care. So I think that just goes to show that it depends where your viewpoint is coming from, and that changing behavior and changing prescribing patterns is exceedingly difficult. But we should always aim to promote what is best practice at the time. And I'm the first to say that I am more than happy to be proved wrong, or more than happy to where evidence suggests something else, and to change my practice on the basis of that. And I think that that is what all healthcare professionals should do.
Fantastic. We need humility in healthcare. That's a perfect place to end. So it's 8:31. We're not going to go any further because we need our rest, we need our sleep, and insomnia is a risk factor for developing chronic pain. So that just leaves me to thank Roger once more for a really fantastic and informative webinar. Thank you for everyone for coming and supporting again, over 50 people. So that's fantastic. Please keep an eye on the BPS's events page as we will continue to make these webinars. And yeah, have a great evening and thanks very much.
Thanks, Graham.